All right, let's talk about one of those calls that gets your own heart rate up. A pediatric patient with a racing heart. Every second feels like an hour, right? It's super high stakes, and you need a rock-solid plan. So that's what we're going to do today. We're breaking down the protocol for pediatric tachycardia step by step.
Okay, put yourself in this scene. You walk in the door, you hook up the monitor, and it's just screaming at you, 2:30. The parents, they're looking at you absolutely terrified. So what's your first move? And yeah, this isn't some textbook question. This is the real deal, where knowing the protocol inside and out makes all the difference.
And here's that plan, our roadmap for today. We're going to cover recognizing tachycardia, what to do the second you're on scene, and then we'll hit that big critical question, is the patient stable? After that, we'll walk down the two different paths for unstable and stable patients and wrap up with the meds and final steps. Let's get into it.
All right, section 1. Before you can treat anything, you have to recognize it, right? And with pediatric tachycardia, it's not just about seeing a fast number on the screen. It's about knowing the specific numbers that matter and putting together the whole clinical picture.
So for our littlest patients, infants, that magic number is 220. Anything over 220 beats per minute, and the alarm bells should be going off in your head. Seriously, burn this number into your brain.
And for a child who's a bit older, the number drops a little, but it's still crazy fast. We're talking anything over 180 beats per minute. That's your threshold, and it means you need to act.
But look, it's never just about the number on the monitor. You have to look at your patient. How are they handling that rate? Are they pale, sweaty, maybe even a little blue? Is their blood pressure dropping? Are they acting loopy or out of it? These are the red flags that tell you how sick this kid really is.
Okay, so you've spotted the tachycardia. Now what? Well, before we even get to the fancy stuff, there are a few things you have to do every single time for every single one of these kids. Think of it as building your foundation for success.
And that foundation is built on 5 key steps. 1. Get some O2 going. 2. Grab a full set of vitals and definitely don't skip the temp because a fever could be driving the whole thing. 3. Get that IV or IO access. You're going to want it later. 4. Get the cardiac monitor on, obviously. And 5. Grab a 12-lead ECG. This is where you gather all your intel.
All right, you've got your foundation set. Now comes the moment of truth. This is the question, the big one, the fork in the road for this entire algorithm. Your answer here changes everything.
And the question is simple. Is your patient stable or are they unstable? Are you seeing those scary signs we just talked about? The low blood pressure, the poor perfusion, the altered mental status. This is your gut check. Time to make the call.
And here's how that decision plays out. If the answer is yes, they're unstable, well, the clock just ran out. It's time for electricity, and it's time now. But if the answer is no, they're stable, okay, we can take a breath. We have a little time to work the problem and think about medications.
So let's go down that scary path first, the yes path. This is for the kid who is circling the drain. There is absolutely no time to mess around.
Your immediate move is synchronized cardioversion. And the dosing here is super important. You start low, 0.5 joule per kilogram for the first shock. No change? Okay, you double it. 1 joule per kilogram for the second shock. Still no luck? You go up to 2 joules per kilogram for any shocks after that. It's a clear, escalating ladder of energy.
Now, I know this is a huge emergency, but if you have a second, and I mean a literal second, and their blood pressure isn't in the tank, think about sedation. A little bit of midazolam, 0.1 megs per kg, can make this procedure so much less traumatizing for the child. It's a huge deal if you can do it. Okay, let's rewind. Let's go back to that big fork in the road and take the other path. This is our stable patient. The heart rate is still flying, but they're handling it for now. So here we get to be a little more like detectives.
And our next clue comes from that 12 lead you got earlier. We're looking at one thing, the QRS complex. Is it narrow or is it wide? If it's narrow, we're talking 0.08 seconds or less, you're almost certainly looking at SVT. But if it's wide, well, that's more concerning. That could be ventricular tachycardia or VT.
So, if you've got that stable, narrow, complex SVT, you always start with the least invasive stuff. Try some vagal maneuvers. For an older kid, have them blow into a straw like they're trying to move a battleship. For an infant, a bag of ice or cold water on the face can do the trick. Sometimes a quick fluid bolus helps too. If none of that works, then, and only then, do we start reaching for drugs.
The wide complex path, though, that's a bit trickier. You have to ask yourself, could this just be SVT that looks weird? Because of that possibility, it's often reasonable to try adenosine first. It might fix it. If it doesn't, or if you happen to know the kid has a condition like WPW, then amiodarone is your go-to. And, of course, if you see that classic twisting pattern of torsades to points, you should be thinking one thing: magnesium.
Okay, we've thrown a lot of drug names around, so let's put it all together in one place and then talk about how to wrap this call up and hand off your patient safely.
Here it is, your medication cheat sheet. Let's run through it. Adenosine. Start with 0.1 milligrams per kg. The key here is you gotta slam it in fast with a big saline flush right behind it. If that doesn't work, you double the dose to 0.2. Got it? Okay. Amiodarone, 5 megs per kg, but this one is slow, over 20 minutes, no slamming. And mag for torsades, 25 megs per kg over about 15 minutes. Getting these details right, the dose, the speed, is everything.
And listen, just because you got the heart rate back to normal doesn't mean you're done. Not even close. You absolutely need a new 12 lead to see the after picture. You've got to keep a close eye on those vitals and stay on that cardiac monitor. And finally, you have to communicate. Let the receiving hospital know what's coming and get on the line with medical direction. It's all about that safe handoff.
You know, it's easy to get focused on the rhythm, but remember what we're really doing here. This whole algorithm, it's just buying time. It's fixing the electrical problem so you can figure out the real problem. Why did this happen? Is there a fever? Is the kid dehydrated? Did they get into something? You're treating the rhythm so you can treat the cause.
So, to wrap this all up, look, algorithms are amazing. They give us a clear path through what feels like total chaos. But at the end of the day, the most important tool you bring to that scene isn't in your drug bag, and it isn't the defibrillator. It's you. It's your brain. It's your calm, your confidence, and your good clinical judgment. That's the thing that's going to save this kid's life.